Hello, everybody, and welcome to the Marfan webinar series. We will wait a couple of minutes as people are signing on. But while we are waiting, you can place in the chat where you are coming from. What country are you located in? We'd love to hear from you. I see London, Belgium, Michigan, Orlando. So we have some people from the States here as well. Detroit. We have some physicians here. Dr. Spin from Stanford. South Dakota, Texas. Many people from the US, North Carolina. London, UK. Oh, somebody from South Africa. The Netherlands. Austin, Texas. It's very good. So I want to thank everybody for coming on this webinar. Today we'll be talking about managing heritable thoracic aortic diseases. And these is going to be about the key insights from the 2024 ESC guidelines. We have three special speakers that are authors of the publication. And they will be dividing their talk into specific parts about the guidelines, looking at imaging, genetics, and management and surgery. So let me forward. So our first speaker for one of our speakers would be Dr. Julie de Backer. She's from Ghent University in Belgium. We also have Dr. Gisela Teixido-Tura from Spain. And we have Dr. Roland van Kimmenade from the Netherlands. So as we are doing the presentation, if you have any questions about the ESC guidelines, some of the presentation that you have seen, we ask that you will post all the questions to the Q&A section in Zoom. We will go and moderate those questions and ask our presenters to answer those questions after the presentation is done. So I'm going to stop sharing, and I think Dr. Tura is going to start the presentation from her side.
Okay, hello everyone. I'm going to try to share first. Hope it works this way. It's fine. Can you see it now?
Yes, it looks good. Gisela,
okay,
thank
perfect. So hello everyone. Thanks for this opportunity from the Marfan Foundation to present these guidelines. For us was as a group really an effort these last 2 years to work together and give birth to this document that was really a big experience for all of us. And first, I would like to explain, of course, many of the ones that are attending might be from the medical community, and then it's not needed maybe, but for the patients or the people that are less less knowledge about what means the guidelines. Guidelines are documents that are made by a panel of experts that define the current scientific evidence on the diagnosis, treatment, and surveillance of a disease or a group of diseases, in this case, the aortic diseases. And these are organized on recommendations and that are approved by the task force that made the document. And this task force included, in this case, also patient representatives. And these recommendations were voted and approved, and also there were an external revision from a group of experts also. So it is a different document as it is another type of scientific document as original articles or other type of consensus. However, it's important to mention that these are guidelines, so do not substitute the clinical judgment and individualization of the medical care. So there's a space for the decisions to be made in a shared decision with the patient, and I think this is really important and was part of the guidelines. So when the document is giving recommendations, these are classified on different class of recommendations, as you can see here in the slide, where there's a class 1 recommendation means that is recommended, class 2A that is should be considered, this recommendation, 2B might be considered, or class 3 when it's not recommended. And then all the recommendations also goes with the level of evidence. So the level of scientific evidence that support this recommendation, being the highest, the level of evidence A, and C, the lowest level, but that it's based on consensus opinion of experts. So in the case of HTAD, heritable thoracic aortic disease, such as Marfan and Loeys-Dietz, there are many recommendations, not all, of course, that are based on a level C recommendation, because these are diseases that have less prevalent and then more frequently less evidence to support the recommendations. We're going to talk so far. First, these guidelines were general for the aortic disease. The last previous European guidelines were in 2014, so 10 years ago, really was a long period before the other guidelines. And these guidelines were for the aortic disease and also peripheral arterial disease. So it's a long document with many other recommendations. But I think this central illustration expresses this need for focus on prevention of diseases, of diagnosis, treatment, and follow-up of these patients, but also the important role of different specialists that are taking care of these patients. So it is important that all together work for the good of the patient. We're going to talk about, my part would be more based on the imaging. It's my specialization for the diagnosis, also for the surveillance. And then Julie DeBacker would talk more about the genetic for diagnosis, of course, and other aspects, and also treatment would be for Roland van Kimmenade. So regarding the imaging, you know that for the aortic diseases in general, imaging is really crucial for the diagnosis and also for the follow-up. It is the cornerstone of the definition of the aortic involvement for HTAD, for example. So it is important that there's a good consensus on how to evaluate the aorta with these imaging techniques, which imaging modality to use, how to measure, how to obtain these aortic diameters that, as you know, it is the basis right now for the indication for example, aortic surgery. So it was one of the importance of these guidelines is to set the basis for what is the indications, how is recommended to do these imaging techniques. So these recommendations were based on a previous recent consensus paper in 2023 for the multimodality imaging of thoracic aortic diseases, giving details on how to measure in the echo, how to measure in the CT and the CMR, how to report the aortic disease and the aortic dimension. So I'm not gonna go in detail on this because I think it's not enough time for this, but is the basis on where we establish the evaluation of the patient in terms of cardiovascular involvement. But some important aspects are in relation to imaging is that it is important to consider when we are deciding which imaging modality for the diagnosis, for the follow-up of patient, to have consider clinical factors to select the optimal imaging modality. So depending on what we want to evaluate on the need for irradiation, for example, for CT or the contrast. So we're gonna decide on these different modality imaging, but also giving importance for the use of CMR, since now, of course, we know that there's no irradiation for CMR, but also we can now use non-contrast CMR for the evaluation of the aorta. So it is especially crucial for the HTAD patient where we know that the follow-up is going to be long. So we want to avoid as much as possible irradiation. Also, you're going to see this figure in the guidelines where we, in the right side in the panel, that there's this upper limits of normality for aortic diameters. These are only a broad approach for this normality of diameters. This is a simplification because, of course, here we are only stratifying by sex, for example, but we are not taking into account age or body surface area. So for HTAD especially, it is recommended to use for definition of aortic dilatation in the aortic root or descending aorta, the use of z-scores where we are putting these aortic diameters in relation to age, sex, and body surface area. For the imaging surveillance of Marfan syndrome, Loeys-Dietz syndrome, and HTAD-related HTAD patients, we designed this algorithm, but it does express the need for clinical or imaging follow-up of this patient with the indication of transthoracic echo depending on the baseline aortic diameter, more or less frequently, more frequently when we are approaching surgical indication, and also the importance of doing baseline CMR, CT for the evaluation of all the aorta in this patient, as you can see here, and also the importance of confirming aortic diameters and evaluating coronary arteries and all the anatomy previous to aortic surgery. So here you can see how was defined for Marfan patients, for Loeys-Dietz, and for HTAD-related HTAD, as I said. And in more detail, when we go for Marfan syndrome, of course, the cornerstone for the follow-up in imaging is for transthoracic echo. We know that at least has to be annually the follow-up of these patients, but it can be more frequent depending on the presence of risk factors or, for example, the rapid growth in some cases. But also the recommendation and how frequent has to be done for CMR or CCT for the evaluation of all the aorta, and also being a little more frequent for these Marfan patients that already had an aortic root replacement. We know these patients are at a higher risk of type B dissection, so complication of the distal aorta. So there was a higher frequency for these patients to perform CMR or CCT. For Loeys-Dietz patient, we know that also they need some serial imaging, but also including head to pelvis CMR or CCT in these patients. So it is a little different than what it is in Marfan, and of course a little more frequent also the transthoracic echo, especially when approaching surgical thresholds. For ACTA2 related HTAD patients, also the indication for a transthoracic echo, and also the follow-up for the evaluation of all the aorta, depending on the presence also of other risk factors. So this was a global approach for the imaging techniques for the HTAD patients, but also taking into account, of course, as I said at the beginning, the need for individualization. These patients might have other diseases or other involvement, such as mitral regurgitation, LV dysfunction, so that might change how you follow the need for other imaging techniques or other frequency of these techniques. This is some recommendations that are more for there's a different scenario in HTAD. So this is for patients, not patients, family members of a family that has an index case with suspicion for HTAD, but we had not identified any pathogenic genetic variant. So we think there's in the index case, in the initial case, this suspicion of having an HTAD, but we are wondering what we have to do with the rest of the family in terms of imaging follow-up. So these are like the minimum recommendation, at least doing transthoracic screening of the aorta in this first degree relative of this case, and also recommendation on when at least to begin at the age of 25 or 10 years below the youngest case in the family, and do not forget to do it in every 5 years until the age of 60. This is as a level of evidence C, so it's a consensus statement. Of course, there's no evidence for this, but this was the agreement to at least recommend this screening with imaging in the first degree relative of a case without identification of genetic, but that we think there's an heritable basis of the disease. So with this, I pass the word to Julie for the part of the genetics for HTAD and all the recommendations.
Okay, thank you, Gisela. Can you, yeah, okay. Yeah. And I will take over here. All right. Okay, so yes, good afternoon or good evening. My name is Julie de Bakker, and I'm taking over from Gisela, and I want to address with you some aspects of genetics and how these have now been included in much more detail in the guidelines than in the previous version. And before continuing, I just wanted to add to what Gisela said. There's an expert team that has been working on these guidelines and expert reviewers, but also important to know is that one of the co-authors of the document was Françoise Steinbach. She's the patient representative, and I think it's really important to have involvement of patients in developing these guidelines. So I just wanted to mention that this has been a patient has been involved, and this is an ESC policy for guidelines in general. So to start on genetics, this is a general slide. This is not from the guidelines, but just to introduce you to what we are talking about. This is from a paper published a few years ago from Bart Loeys group, giving a nice overview of what risk factors for thoracic aortic disease are composed of, and we are all aware of age, increasing age, aortic growth, and then hypertension, pregnancy playing a risk, specific treatments, and smoking. And there's emerging, or maybe as of today, not so emerging anymore. There's a few markers that can indicate aortic dilatation, aortic lengthening, tortuosity, stiffness, and then certain biomarkers and microcalcifications. But what we are talking about here are the genes, and genes can be grouped into genes that are causal for Loeys-Dietz syndrome, so the TGF-beta signaling genes, the ACTA2 gene, as already mentioned, and then the fibrillin-1 gene for Marfan syndrome, and the COL3A1 gene for vascular EDS syndrome. The term heritable thoracic aortic disease, and I'm actually quite happy that this term has been adopted in the guidelines, not only the ESC guidelines, but also the American guidelines and the recently published surgery guidelines. This is a group of disorders that can be genetic, so with an underlying genetic defect. But in some cases, we will have like families where there's no known genetic defect, and these are then familial, but these can also be heritable. So if it runs in the family, even if you don't have a genetic a causal genetic defect, then it can be considered as heritable. And in this group, we can also distinguish between syndromic, so Marfan syndrome, for example, with the typical features, and non-syndromic presentation. So some people will have aortic disease in isolation without having other outward features. And in the guidelines, and this is also very important, this is something that has evolved. We have emphasized that the management of patients with HTAD, oh, I'm sorry, moving too fast here, should be individualized and based on shared decision making. So guidelines are very important, and people follow, or we are requested to follow the guidelines, but we always have to bear in mind that each patient is different, and in some cases you cannot apply these strict guidelines to an individual patient. So it's very important to look at the individual patient and make the decisions along with the patient. And we also wanted to emphasize that it is important and recommended that patients with these diseases are evaluated in the center with expertise in the care of these patients. This is an algorithm, and I know it's quite busy, so I have split it up. It's the algorithm for genetic and imaging screening in patients with thoracic aortic disease. And this is the upper part where we move from a patient with thoracic aortic disease, so can be either dissection or dilatation. And the first item that we check is the age, and there's an arbitrary, I will emphasize this, an arbitrary limit of 60 years. This is in alignment with the other guidelines. And then you can move either to the left in patients that are older, or to the right in patients that are below 60 years. In the older group, you will look for the diameter. And as Gisela has already mentioned, we will look for Z-scores, and the Z-score above 3. And then you will check for hypertension, yes, no. If there's no hypertension here, you will move to referral. And in case of hypertension, you will look for additional risk features to guide you towards referral for further evaluations. If you have a patient younger than 60 years, and this patient presents with a dissection, you will directly move downwards. And in case of dilatation, you will again look for hypertension, and then you will guide your management with the diameter, again looking at Z-scores and additional risk features. And when adhering to these values, you will refer those patients to a center with expertise. And the additional risk features, obvious risk features, syndromic features of Marfan, Loeys-Dietz, or vascular EDS, or any family history of thoracic aortic disease, intracranial or peripheral aneurysms, or unexplained sudden death below the age of 60. And then moving to the lower part of this algorithm, so we are here, we have referred the patient to a center with expertise, and then in parallel, you will go for aortic imaging, as Gisela has nicely explained. So what the imaging of the first degree relatives as a class 1 recommendation, and then for genetic testing, of course, after counseling of the patient. And then you have scenarios where you have a positive result with a genetic cause identified, or you can have a negative or a VUS. And important here is to know that these patients may need re-evaluation, or the genetics need re-evaluation in the proband. And then, as Gisela has already mentioned, re-imaging of the first degree relatives. And then based on if you have a positive or an abnormal result, you can go for cascade screening and then gene-based management as a class 2A recommendation. And this gene-based management, this is based on some evidence. This doesn't come this doesn't fall from the sky, but it's based on evidence that I will briefly explain to you. And this is then as worded in the recommendation, and some further recommendations that we have made. What is also important is that in the setting of patients with aortic disease, that family history information is gathered, and it's not just a simple question, is there anyone in the family? You really have to sit down and draw a three generation pedigree of these patients for detailed information. I mentioned the importance of genetic counseling, so genetic testing should be accompanied with genetic counseling, explaining the how, the why, the when of genetic testing to these patients. And then in patients who have a pathogenic or likely pathogenic variant, cascade screening can be initiated, and this is, or it is recommended actually, and this is irrespective of the age. And then, as I mentioned, we can or our management should be guided, or it should be considered to guide your management by the underlying gene or the variant. And this comes from data that have been gathered over the last year. So this is data from the Montalcino Aortic Consortium. This is looking at diseases, so Marfan, Loeys-Dietz, and then the non-syndromic HTAD related diseases. And you can see that patients with the non-syndromic forms will more often present with aortic dissection than, for example, patients with Marfan or Loeys-Dietz syndrome. And this is important to bear in mind because patients with Marfan or Loeys-Dietz syndrome will often be picked up with other manifestations before they move on to dissection. And these are really the difficult situations where there is a proband in the family presenting with dissection, and then the whole family gets involved. And this is, again, these are follow-up data from the Montalcino Aortic Consortium, where data of patients with genetic defects in smooth muscle cell genes or the TGF-beta genes have been, the clinical data have been gathered looking at aortic outcome. And I'm not going into too much detail, but just to show you that looking at the difference between smooth muscle cell genes and TGF-beta genes, there is no difference when looking at any aortic event. But when you split this up into aneurysm surgery and then dissection here on the lower part of the panel, you can clearly see that patients with TGF-beta gene mutations will more often have elective surgery as an aortic outcome. And the opposite is true for aortic dissection. As I mentioned, patients with TGF-beta mutations will less often have aortic dissection as compared to patients with the non-syndromic forms or the HTAD. And then looking into even more detail, we see that patients with the different types of Loeys-Dietz genes, so for example, the SMAD3 versus the TGF-beta receptor 2 genes, if you look at a patient of 40 years old, a SMAD3 patient will have 15% of an aortic event, whereas TGF-beta receptor 2 will have a 50% chance. So this is a really big difference. Syndromic manifestations play a role in dissection presentation. Smooth muscle cell genes have dissections at lower diameters, and there's a preponderance for childhood onset disease in the TGF-beta receptor 1 and 2. And this information is then put into the guidelines, and this is where this gene-based management comes from. So data have been gathered, and data do support gene-based management in our decision making. And Roland will also allude to this when it comes to surgery. Talking about medical treatment briefly, so Marfan syndrome, there's evidence in Marfan syndrome for beta blockers or an angiotensin receptor blocker, so losartan as the most known example here, should be given. So it's recommended as a class 1 recommendation in maximal tolerated doses to reduce the rate of aortic dilatation. And then in patients with Marfan syndrome, the combination of a beta blocker and an ARB again, in maximal tolerated doses can be used as a class, should be considered. So this is class 2A recommendation. For vascular Ehlers-Danlos syndrome, there's evidence for celiprolol, and we have this as a class 2A, so should be considered in patients with vascular EDS. To end, I would like to spend a few words on pregnancy, because we also have some recommendations there, and data on pregnancy and heritable thoracic aortic disease so far have largely been retrospective data gathered from the known GENTAC registry, where aortic dissection rates increase ×5, ×8 during pregnancy. And type A dissection occurs in equal prevalences in type A and B is equally presented. And there's case reports in literature that the dissection rate in women with prior aortic root replacement might occur more frequently. And these are data from the ROPAC registry. So this is a very big international registry on pregnancy and cardiac disease. And in the second half of the ROPAC registry, patients with aortic disease have been included, over 500 patients in total, and the inclusion started in 2018, which was after the previous guidelines on pregnancy. And just to show you that in this cohort, so you have Marfan patients, Loeys-Dietz patients, ACTA2 patients, and then a number of patients with unidentified aortic disease, there was no maternal mortality. And this is really an important message, but there were 5 cases of aortic dissection, and I'm showing these here. So there's aortic dissection occurring in the case of Marfan syndrome about mid-pregnancy, 17 weeks. One woman with an unknown genetic aortic disease at 38 weeks, and then 3 more Marfan patients post-delivery. So this is important also to acknowledge that the post-delivery phase is a critical phase for aortic dissection. But I also want to point you towards the information that 3 out of these 5 dissections were type B dissections. So really, this is really an important point to make, that it's type A. We are guided by the diameter, but this is not so much the case in type B. And I think this is one of the reasons why we see more type B dissections. So this is my last slide on recommendations for pregnancy in women with Marfan syndrome. So the need of a preconception evaluation in these patients by a pregnancy heart and vessels team is highly recommended. It's important to acknowledge that it's not just the women that we need to see, we also need to see the men, because there's the transmission risk, and patients need to be offered preconception genetic counseling. An imaging study of the entire aorta is recommended prior to pregnancy, and then follow-up will be determined by the diameter of the aorta. So the frequency will depend. If higher diameters, more frequent follow-up will be needed. Beta blockers can be given and are even recommended during pregnancy. And then prophylactic aortic root surgery may be, so it's recommended, especially if the aorta goes over 45 millimeters, and may be considered in diameters between 40 and 45. Losartan, so the ARBs, cannot be given during pregnancy because they have teratogenic effects. And this is my last slide, and I'm going to give the word to Roland now.
Thank you, Julie. And good morning, good afternoon, and good evening to everybody. I'm going to try to share my slides with you. Hope you can see them now. So I'll take over from here. So just the first word on the differences between Marfan syndrome, Loeys-Dietz syndrome, and
Roland, I don't see your slide. I don't know if I'm the only one, but
Yeah, we can't see them yet.
you can't see them yet. So let me try them again.
I think this is, oh, yeah, this is.
Do you see them now?
Yeah. Thank you.
Okay, it's always a challenge. So first I would like to share some differences between Marfan syndrome, Loeys-Dietz syndrome, and Ehlers-Danlos syndrome, which I will get back to later. So this illustration is the illustration of a cell. So the upper part is outside of the cell, this is your cell membrane, and this is the nucleus of the cell. So these fibers are fibrillin 1. And if you have Marfan disease, there is some kind of genetic error in one of these fibers, which causes Marfan syndrome. So it's one of the ideas in the beginning was that Marfan syndrome gave dissection because outside the cell, the tissue was more vulnerable because there was a problem with one of these fibers. But what was actually the case is that these fibers contain TGF-beta. And TGF-beta is a protein that accelerates all kinds of processes. And what TGF-beta does, it stimulates a receptor, and Julie already told some stories about these receptors. And this receptor gives TGF-beta a signal to other proteins, which accelerate all kinds of processes to the nucleus of the cell. And the nucleus of the cell is actually the headquarters of your cell, which control all kinds of processes. And what happens with Marfan syndrome actually is that if these fibers are more vulnerable, TGF-beta will not be contained by the fibers, and there will be more TGF-beta activity stimulating all kinds of proteins and accelerate all kinds of processes in your cell. And this ultimately results in all the problems that you can face in Marfan syndrome. So Marfan syndrome is a problem in one of the fibers containing this protein, and Loeys-Dietz is a problem in one of the proteins that transmits this signal from this TGF-beta. So this is the interaction or the correlation between Marfan syndrome and Loeys-Dietz syndrome. So there is an interaction with this receptor in the cell membrane, and this receptor is actually blocked by losartan. It's the AT1 receptor. And this is why we prescribe losartan to patients with Marfan syndrome or Loeys-Dietz syndrome, because we hope to slow down the processes which are accelerated by this TGF-beta protein transmitting signals to the cell. So this is the scientific background why we were studying losartan in this kind of syndromes. So going back to the concept of Marfan syndrome and Loeys-Dietz, and why are we actually measuring diameters of the vessels? So I like this model of this inflated glove, where the fingertip you can consider as a normal aorta. So the diameter is normal, and this is an aneurysmatic aorta, where you can see that indeed the diameter has been increased. But what is more important to realize is that what we call the wall tension is higher in this part of the glove. So this means that there is more wall tension in this part rather comparing to this part. And you can immediately understand that if you put some pressure on this part of the fingertips, nothing will happen. But if you put some pressure over here, then a tear could occur. And this is why we measure the diameter of the aorta in patients with Marfan syndrome of Loeys-Dietz syndrome, because there is a correlation with the diameter of the vessel and the occurrence of adverse events. And this is different in Vascular Ehlers-Danlos, because Vascular Ehlers-Danlos is more a problem of the vulnerability of the tissue. And I always make the comparison with a wet newspaper, because a wet newspaper can tear at any moment and is not really related to wall tension when compared to Marfan syndrome or Loeys-Dietz syndrome. So this is also what you can see reflected in the guidelines, that we especially measure diameter in Marfan syndrome or Loeys-Dietz syndrome, but it is more difficult to predict events in patients with Vascular Ehlers-Danlos because there is less correlation with the wall tension in this kind of diseases. And you can see this in our guidelines. So surgery is indeed indicated in patients with Marfan syndrome who have aortic root disease with a diameter of 50 millimeters. That has always been in the previous guidelines. This has not changed. And when we perform surgery, we try to preserve the aortic valve in patients, because it's always better to have your own valve than have a prosthetic valve, a bioprosthetic valve, or a mechanical prosthetic valve. If it's necessary, if the valve has been damaged because of dilatation or other diseases, then you have to replace the valve. But if it's possible, we like to preserve the valve because it decreases problems in the future. And we consider surgery in patients who have an aortic root aneurysm and a diameter of 45 millimeters if there are extra risk factors which indicate that the risk for a dissection is increased. And this is, of course, of the thoracic aorta. And in the arch, the descending aorta, or the abdominal aorta, 50 millimeters is the diameter which we advise to undergo surgery. And this was already to a level C recommendation in the previous guidelines. There are no new insights in this part of our knowledge. Open surgery has always been the preferred therapy in patients with an Marfan disease or when they have an aneurysm. However, we now also say that there is a potential for endovascular procedure. So how does this work? So what's an endovascular procedure? So in an endovascular procedure, you implant a stent using a catheter over an aneurysm, and this is why how you close the aneurysm. These stents are actually designed for patients with atherosclerotic aneurysms. And why is this? And I just put on this illustration. This is actually not an aortic stent, it's actually a venous stent, but it nicely shows the point that I want to make is that at the end of the stent, there is a divergation of this, what we call struts. And why is that? Because if you want to stent an atherosclerotic aneurysm, you want to pinch these stents into the vessel wall, which are in atherosclerosis highly calcified. So you are sure that this stent is stuck over there because you don't want it to move with every heartbeat downstream. And this works perfectly in atherosclerotic aneurysms, but you of course don't want to pinch a stent in a vessel wall which has a connective tissue disease, because you can potentially cause problems. So we never ever put stents in patients with connective tissue disease. However, we now have some experience, and also in our center, that if you have operated upon a patient, then you can perfectly put a stent in the prosthesis that was already inserted on a surgical manner, without causing any problems for dissection in these patients. So indeed, we have personally also successful results in putting stents in patients who already underwent prosthesis, but it is not preferred to put a stent into a patient who has never been operated upon. So putting in endovascular stents in patients with connective tissue disease should only be done in centers with experience in this field. So also comparing Marfan and Loeys-Dietz syndrome, aortic root replacement should be considered in patients with Loeys-Dietz syndrome if the aortic root exceeds 45 millimeters, and it may be considered to adjust the threshold according to the underlying gene, taking other risk factors into account, as was also demonstrated by Julie. Furthermore, for medical therapy, we advise losartan. And why is this the case? This was a study done already in 2006, where it was shown that in mice, if you look at the aortic vessel wall, this is a normal aortic vessel wall in the mouse. If a mouse suffers from Marfan syndrome, you can see that the aortic vessel wall is is more irregular compared to a normal vessel wall. If you treat the mouse with propranolol, you see that the vessel wall becomes better organized. But if you treat the mouse with losartan, it actually looks like a perfect normal vessel wall. So this is why we studied losartan, because we thought that losartan might even cure connective tissue disease. But unfortunately, when we tried this in human patients, it was not as successful as you can see here. However, we do see that less events happen in patients when you treat them with medical treatment. And as Julie already said, we recommend the treatment with either a beta blocker or losartan or another ARB in patients with Marfan syndrome, or the combination of both. And in patients with Ehlers-Danlos, we think that celaprolol should be considered. Looking at physical activity, it is recommended to individualize physical activity. It used to be discouraged physical activity. However, we see that in patients with connective tissue disease, physical activity is a good thing. It keeps you in a better cardiovascular health status, but also a lot of patients have other problems, for instance, with their joints, and it's good to work out in a manner that suits you best. in order to prevent problems on other organ systems. Regular moderate aerobic exercise is indeed encouraged. And also in patients who present with aortic dissection or have undergone aortic surgery, post-operative cardiac rehabilitation is of importance. Lastly, also we discussed Loeys-Dietz syndrome, and I showed you the illustration with the several proteins which are involved in transmitting a signal from TGF-beta to the nucleus. And we now know, as Julie has showed you, that it differs which protein is involved in Loeys-Dietz syndrome, which can cause more or less harm. And this is why we also individualize the thresholds for aortic surgery in patients with Loeys-Dietz syndrome, depending on their mutation. And this is actually the part that I would like to share with you. And thank you for your attention. And of course, we're all happy to take any questions.
Thank you very much. I really appreciate that summary for these new European guidelines. So we have a few questions that have come through. I will start by maybe asking Julie to answer this one. So this patient is a newly diagnosed with VEDS at 51 years of age. And she's asking whether the condition lies dormant or has she had it since birth, because she didn't have symptoms early in life. And who should lead then her care for this disorder?
Yes, thank you for that question. So vascular EDS is a genetic condition. So basically, you are born with that condition. If you look at it from a genetic point of view, it is a disease of collagen. So the collagen production, or the collagen quality actually, and it's one specific type of collagen, it's collagen type 3, has a lower quality. And the collagen, what is important to know about collagen is that this is a protein with a very long half-life. So the collagen that you are actually born with, you go on with that same collagen for a long time. And this means that the lower quality or the lower amount of collagen that you are born with as a vascular EDS patient is already there at birth, basically. But why some patients present with manifestations at a younger age and others will not present with manifestations until mid or even later age, we don't know the actual cause yet of why there is this variability. There is definitely some difference between the type of mutation. So if you have a glycine substitution, which means that one of the building blocks of the protein is replaced by another one, you will have, generally speaking, a worse outcome than when you have a lower quantity of the protein. So if you have a less good quality, will give you a worse outcome than when you have a lower quantity of the gene. This is maybe a bit too simplistic, but it's the way to explain why there's differences between people. So the type of variant that you have will already be one of the explanations for why you might not have had any symptoms or problems until later in life. But there's many other factors that definitely play a role. There's external factors that play a role. There's, like, for example, blood pressure when we're talking about the vessels. And it is actually a disease. And again, I mean, some people will have like easy bruising from childhood onwards, and others will only present with these bruises later on in life. But if you go back carefully, I think most people will say, okay, well, I have known for a while that my joints are a little bit more lax, or my skin is like thinner, or has always been like thinner than the usual skin. But it's definitely a fact, a given fact, that some people will not have these typical vascular EDS facial features, this triangular face, these absent earlobes and thin lips. This is not present in everyone. And we see that not only in vascular EDS, we also see that in Marfan syndrome and in Loeys-Dietz syndrome, that since we do more testing now, we do more genetic testing for various reasons in the population, and we find more genetic defects, mutations, abnormalities, which are not necessarily always linked to a specific phenotype. So you may have a very mild phenotype despite having a pathogenic variant, and this is something that we need to take into account in our clinical practice, that we are dealing with a much milder end of a spectrum nowadays than we used to do in earlier days, where people were diagnosed based on clinical features. We didn't have the genes, and these were very often more severe cases, whereas now we actually see a full spectrum. And then to answer the question, who should follow up, this is I think highly center dependent. In Europe, there's many centers where people with Marfan syndrome and people with vascular EDS are followed by the same group of people, so in the same institution and by the same group of people. But there's institutions where this is separated, where different teams will manage patients with vascular EDS, and other teams will manage people with Marfan syndrome. It all depends a little bit on the local situation. The size of the population plays a role. I think the Marfan Foundation should be able to maybe guide you in where the place where you live, to help you find the best team to manage your follow-up. And yeah, again, it's something that is locally different.
Yes, thank you. Thank you, Julie, for that answer. I think this question was probably for Roland. For ascending aortic aneurysms, do the ESC guidelines take us back from 5 centimeters as a threshold for high volume regional centers towards 5.5 centimeters as a recommended threshold, except where high risk factors are present?
So 5.5 is for patients without any connective tissue diseases. So for Marfan syndrome, it's still 5.0 centimeters when there is an absolute indication, and 4.5 when there are risk factors. And of course, this is an individual decision. Some patients have a lot of family members which have severe aortic problems, which makes them less comfortable with an aortic or ascending aorta of 4.5. So I think that this is something that you should discuss with your doctor, and I think that patient preference is actually very important in this decision making, especially also with other techniques, like for instance the Pierce technique, where we see that the Pierce technique seems to be less invasive for patients. That patients who feel uncomfortable with a dilatation of the aorta to choose, especially for the Pierce technique. And I think this is something you should discuss with your treating physician.
Thank you. Thank you, because we also had a question on pairs and your thoughts on that. So that would be great. Thank you very much for that. This is for Gisela. Can you speak to the pros and cons of MRA versus gated CT for measurements of the aortic root in LDS, or whether there is a case for both tests in surveillance?
Yeah, so there's an obvious pros and cons between the two techniques in general, such as the CT implies irradiation, of course, but every day this is going lower because of the techniques, and the machines are getting better in this. Especially for the measurements of the aortic root, that is a hot thing for the Loeys-Dietz and for the Marfan, where the diseases affect first. It is important that the CT is a gated CT, so that the study is done taking into account the movement or the cycle of the cardiac cycle, so that you don't get a blurry image. That's why the gated CT is really high on spatial resolution and having really nice images. For MRA depends, so it's a bit technique, but depending, you might have an MRA without ECG gating. Then for the study of the aortic root wouldn't be the best thing, I would say. But in general, when you are using CMR for the study of a patient of Loeys-Dietz and Marfan syndrome, you get whether a cine image of the aortic root or some non-contrast sequences where you get really nice images. So if you get this into consideration, you can have either good images with CMR or CT. So it has to be a place where they know how to take the better images of the aortic root in these patients, especially because, as we have said during the presentation, aortic diameters are really important for the decisions, surgical decisions, diagnosis. So we really need to have good images. Apart from that CMR and CT, you're going to get an overall assessment of the aorta, but also the aortic branches, where, especially for the Loeys-Dietz, there are many. So it's possible to have peripheral arterial aneurysms, so aneurysms of the branches of the aorta, and you want to really take a look at this, not only intracranial, but also even for the visceral arterial branches of the aorta. So it is important that whether you are using CT or MRI, you are really taking a look to these branches of the aorta. So I think the important is that the physician that is taking, so is giving the decision on which image, he knows what's the possibilities in their center. So the type of machine, the type of sequences and experience in the center, and then the sites depending on this.
Thank you. We have several other questions, so I'm going to keep on going for another few minutes. Roland, can you talk a little bit more about exercise? This family has genetic testing, and they are in the VUS category, but they have been affected by aortic aneurysm for 3 generations, having aortic aneurysm repair and valve replacements. And right now they feel their cardiologist just tells them to do exercise, that they're not holding their breath or not to grunt. Can you explain more what you mean by, moderate exercise for patients that have these conditions?
So I think that our insights have been changed the last 2-3 decades, where in the past maybe patients were advised to strictly not exercise when you have a connective tissue disease. We now see that if you perform exercise, this is actually the best way to keep your body in shape, but also your cardiovascular health in shape. So performing exercise is the best way to lower your blood pressure. So indeed, sometimes patients are afraid to perform exercise, and I'll always say, like, if you do some exercise a day, maybe your blood pressure might increase a little bit during the exercise, but the benefits on the other hours of the day are really outweighing the little elevation in blood pressure that is happening during exercise. And actually, we performed a large study, which we will publish within the next month, that actually shows that in Marfan patients, it looks very safe to perform exercise. So I'm not afraid to advocate exercise in patients with connective tissue disease. However, you should be aware that this is not a disease to become a bodybuilder. So you should really avoid peak strength exercise. This is something I would disencourage. But it's definitely good to be in a good cardiovascular shape.
Thank you. So there is a question here about celiprolol not being available in the United States, but currently you can go into a trial with celiprolol within the United States. If you're interested in doing that, just contact our Help and Resource Center and we can give you the information on how to enroll in that trial. But if celiprolol is not available, what other kinds of medical management recommendations would you have for VEDS? So is another type of medication available? Julie?
Okay. Yeah, I can take that. So yeah, I'm aware of the unavailability of celiprolol in the US, and we would recommend there's other beta blockers. So celiprolol is a very specific beta blocker, and one of the properties of celiprolol is that it has vasodilating effects, and there's other beta blockers that have a very similar effect. So there's Nobiten, Nebivolol, for example, which is, to my knowledge, available in the United States. And you can, I mean, we would recommend that people take drugs that are not exactly the same, but that are similar, very similar to celiprolol. And even, I mean, within the group of beta blockers, there's some differences. Some are more cardioselective than others, but you should talk to your treating physician. And I think that the other beta blockers also do their job in what you want to have is that the shear stress on the walls of the vessels goes down, and you can achieve that with other types of beta blockers than celiprolol as well. And there's maybe important to mention, there's one trial that has not been published yet, but I heard it. I saw the presentation of this at a meeting using angiotensin receptor blockers. It's a French study. They have used the combination of celiprolol and angiotensin receptor blockers, and apparently in that study, it was a small study, but the combination of the two might even be better in patients with vascular EDS. But we of course, yeah, the results are there. They need to be published. But I think angiotensin receptor blockers hold some promise as well for patients with VADS.
All right, thank you. Here's another management question about medication. Are there side effects that come from losartan? Julie?
Yeah, I can go on. Side effects from losartan. The main concern is there's very little side effects. One of the side effects, and this is maybe important in setting of people who do not have hypertension, because the first indication for angiotensin receptor blockers was actually, one of the first indications was elevated blood pressure. And if you take such a drug and you have a normal blood pressure to start with, then there is a risk that you might drop in blood pressure, and that you might feel a little dizzy, and you might have side effects related to that. The other aspect to take into account, but this is really very uncommon in the setting of thoracic aortic disease, is that it can affect your renal function. So we normally recommend that patients who are initiated on these drugs have their renal function tested. So it's a blood test. You have your potassium level and your renal function test done a few weeks after the start of these drugs. But again, this is very specific to patients who have renal artery disease, and this is not something that we commonly see in patients with thoracic aortic disease. So that's a bit of a concern. But other than that, there's very few side effects of these drugs, and you cannot take them in pregnancy. But I mentioned that.
Yeah.
Just make one comment on what Julia is saying. So indeed, these drugs are sometimes called vasodilators. This does not mean that it forms an aneurysm. So vasodilating means that it relaxes the vessel, and this is how they decrease your blood pressure. So I sometimes get the question, it says it's a vasodilator. I should not be taking it because it gives an aneurysm, but this is a confusing term. It should not be confused.
True. Okay, thank you. Roland, maybe you want to take this one. What's the difference between a type B and a type A dissection, and how is it related to pregnancy?
So what we call a type A dissection means that it's in the ascending part of the aorta, and a type B dissection if it's in the descending part of your aorta. So a type A dissection is more dangerous because it can immediately cause any problems. So if you present with a type A dissection, you will immediately receive surgery. A type B dissection can usually be treated conservatively, and we'll wait and see. We lower the blood pressure, we give pain medication, but it does not necessarily mean that you should be operated upon immediately. This is also because a type A dissection may involve your coronaries and the blood vessels to your head. And if the dissection involves those, you can suffer from a myocardial infarction or, for instance, a cerebral infarction. So this is why we are very actively operating upon type A dissections, but we can remain more conservative on type B dissection. So this is the difference between a type A and a type B. Another difference is that a type A dissection is more related to the diameter of your vessel, while a type B dissection occurs more independent of the diameter of your descending aorta. And this is also what Julie was mentioning during pregnancy. You can measure the descending aorta, but it is very difficult to predict if this is a descending aorta at risk for a type B dissection or not.
Thank you. Here's a question again about ARBs. Is the use of ARBs recommended in a Marfan patient whose blood pressure is normal to low? And this person has an abdominal aneurysm, which is followed annually, and the surgery is not indicated yet. So would the ARBs lower their blood pressure too much? Who would like to take that?
Well, I started on the ARBs. I can continue. I mean, what was shown in the big trial comparing losartan and atenolol, the Marfan trial, many years ago now, but the big trial in the pediatric population, especially in the pediatric population, these children do not have high blood pressure. On the contrary, they tend to have like low blood pressures. And what was seen in that study is that the giving losartan in a normotensive person, so someone who has a normal blood pressure to start with, it doesn't seem to have the same blood pressure lowering effect as when you give it to a person with a high blood pressure. So the blood pressure lowering effect of an ARB in someone who doesn't have a high blood pressure to start with is much less pronounced. And actually, losartan was very well tolerated in that study. This was evaluated with questionnaires. It was very well tolerated, even in higher doses. So I would not be too afraid to start on an angiotensin receptor blocker. I would definitely give it a try, and of course you should titrate. You should start with a low dose, and if well tolerated, you can go up. You shouldn't start with 100 milligrams of losartan as the initial dose, but when you start with a low dose and you can gradually increase, then I think tolerance will be okay. I think in most people that we see, it is okay, and I don't know if Gisela or Roland have the same experience, but it's well tolerated.
Yeah, actually, I think in general is so that the frequent scenario is that these are patients that are not hypertensive in general, especially when they are not dissected, that they don't have previous history of aortic dissection. And so we give this medication, of course, with up titration, so progressive. I would say maybe that in Spain, because of the hot weather, the tolerance is a little less, I would say, because sometimes we talk about this. And but if you do it progressively and it's well tolerated, so it's just a matter of adjustment.
Thank you very much. We are approaching 2:15 here, so I want to be mindful of your time. I'll ask one more question, and then for the other questions that I haven't gotten to, please, you can send them to our Help and Resource Center at marfan.org/ask, and we'll be happy to get those to you. So the last question is, this person has a child with Marfan syndrome, and he has aortic dilatation, and he has only been given propranolol for this 6-month baby. Can he use losartan? Who would like to answer? Gisela?
Yes, so I understand it's 6 months old, the baby?
Yes. Mm-hmm.
So I'm not a pediatric cardiologist, but I think that IRB are more prescribed, I don't know, a little after that. So like, I don't know if it's 1 year, 2 years, maybe Roland knows better than me. But I think that the medication protocol for really these little babies is different, because I think it's because of renal contraindications in little babies, but maybe I'm absolutely wrong. So I'm an adult cardiologist on this, and I won't make a decision on this. Maybe Roland knows.
Yeah, well,
Roland?
I'm not a pediatric cardiologist either, but I believe that losartan inhibits your bone growth in little children, and this is why pediatric cardiologists prefer not to prescribe losartan in very young children. But again, children medicine is a different specialty from adult medicine, so you should always consult a pediatric cardiologist for that.
All right. Well, thank you so much. I really do appreciate your time, and even to our audience who has provided us with lots of interesting questions. I would really appreciate your feedback. For those of you that have been in this webinar, we have a feedback form for community members, others for healthcare professionals, and we appreciate if you could fill out this survey to let us know how we can improve these webinars. Thank you very much for your time and for all your work in this. Take care.
Thank you. Thank you
Thank
very much
you.
for having us.
Thank you.
Thank you, bye.
Okay, bye.